All right, well, ladies and gentlemen, boys and girls, we're gonna give the AV team here just a minute to cue up the music to get this started, as this is the event that you've all been waiting for. Some would say that this is the greatest event in all of ophthalmology. Some would say that this is the greatest event in all of medicine. But Max Golden Shoe would say that it is the greatest event in all of sports. It is time for the 49th Super Bowl of Grand Rounds. All right, thank you. Thank you, AV team. But first, we have a little bit of a history lesson here. Let's remember the real Super Bowl 49 when Tom Brady and the New England Patriots went on to defeat the Seattle Seahawks. I'm sorry, Seahawks fans. Is he the GOAT? All right. 7 Super Bowls. Well, you know what? Dr. Andy Doan's been teaching us a lot about AI and ChatGPT this week. So I said, I'm going to go plug it in. One name, no hedging. Greatest football player of all time. It says Pelé. I was like, no, American football. All right, this is America. What is this guy? Okay, Brady. All right, oh, that's not good enough. I want the full name. So we got Tom Brady. There it is. I didn't prompt it at all, okay? This one I might have prompted. One name, no hedging, greatest Super Bowl winner, COS Super Bowl winner of all time. Max Sue. I said, try again. We got the right answer. And we're going to remember Super Bowl 43, okay? I think I put this picture up every time I talk here. I'm going to remind Max every time. I'm sorry, brother. This was Super Bowl 43. I won desktop cornhole and a blah button, okay? So I want to thank Dr. McCauley for the blah button. All right, I think Max won like a singing goat, all right? And here's the thing. There's a big prize today, all right? And I was telling the residents last night, I'm like, guys, bring your A game tomorrow. We're giving out a huge prize. They didn't believe me. I still don't think that they do. I don't know if it's a secret or not. So I'm not going to give away this prize. We're going to give these away right before the break, all right? We'll have time to vote, and I'll tell you how to do that in just a minute. But this is big time. This is the all-time. Love the blah button, man, but I feel like we got a little bit bamboozled after you guys see what the prize is today. Still have it. All right, so Max did not stop there, all right? If we remember Super Bowl 46, all right, he came back from behind, and he won that Super Bowl 46. I had to just throw that out there. I'm crying foul, if you can see that on the screen there. I don't know if that's a thing or not. Was he deflating microphone footballs? Anyway, whatever. Okay, let's get to the nitty-gritty here. Hold the music 1 second, guys, 1 second. Little housekeeping, but that's about, we're almost there. I don't know where my images don't come through. But if you got the app and you want to pull up the schedule for today and wait until the end to vote. But if you go to if you go to the schedule for where we are right now by 8:15 COS Super Bowl Grand Rounds, you will see a little icon that says polls right next to the app. If you click in there, and then Stan Pletcher's got this live now. So does anybody have any questions about voting? If you do, let me know. We have some time. We'll have you get your votes in before the break this morning for exhibitors. At that time, we'll have everyone come up here. We'll announce our winners. We got prizes for first, second, third, and fourth, and some prizes for everyone that's participating. So
for the non-millennials in the room, can you go through, like on the app, do they hit the person? Do they hit the...
Yeah, so just to go through this one more time, if you pull up the app and then you hit on the, let's see here, Super Bowl of Grand Rounds, and then there's a little icon right there, and then you'll see this where it says Super Bowl. Click on it again, and you'll have the option to vote. Clear? Any questions, anybody? Okay. And then find me at before or after the talks. But let's get this going here. And we can cue the music. And it is time. We're going to call up our presenters here. Hailing from South Africa, we have her talk titled The Other Great Imitator. It is Emma Pons. have OMS 4. His talk is titled An Artesian Extraction, Removal of Phakic IOL, and the Art of Precision. Please welcome Brian Munoz. Woo. All right, from New York, we got confounding case of conjunctivitis. Please welcome Melissa Warren. Woo. Yeah. All right, a COS board member here on the stage. We've got tonight on tap at Hazy IBIA, we've got Kevin Wong. All right, and another contender here. His talk's titled Leaving Orbit from Kentucky. We've got Cody Blanchard. And last but not least, we have Mount Doom, a fiery red and yellow Discovery, Daniel Berry. Oh, keep that music going. I screwed up. Yeah. Give me the music one more time. I'm sorry, I added one slide. I don't know how I forgot this. But his talk is titled, I Can't Stop. Please give an extra hand for Ryan Harple. Thanks, brother. Sorry, man. I added it, but then all right, guys. So, here they are. Thanks for the contestants. We are gonna hand the mic over to Emma Pons here. Dr. Pons, if you want to grab, did they mic you up or do we have? Grab the handheld here and hand that off to the next contestant. You are first, so let's cue up her talk, and then we'll be handing it off to right after her talk. We got Brian on deck, okay? All right, here we go. Thank you, guys.
Do I need a clicker?
What's up? Oh, yeah.
Okay.
Clicker, and there's our talk, and let's do it.
Okay. Good morning, everyone. Thank you for allowing me to be here. Thank you that I can start this off. So just before I get into my topic, I'm writing this the wrong way around. Before we get into this topic, I had to look up what a Superbowl is because we don't have NFL in South Africa. So just to explain, this is a rugby jersey. This is the closest thing we have to NFL. So this is my husband's jersey. And so I was really inspired by Dr. Doan's talk, and I just thought, well, let me ask, I chose Grok to please help me imagine what it would look like for the Springboks, our rugby world champions, to verse, I think your champions are the Philadelphia Eagles, if I'm not mistaken. Otherwise, that's ChatGPT's fault, because I asked. And this is what it gave me. So I said, well, can you try and make it look like the Springboks are winning, please? And that's what they gave me. Chaos. Even I know there's supposed to be only one ball in play. So without further ado, I'd like to introduce the other great imitator. Osler was right in that syphilis is the great imitator, but I'd like to introduce you to the other great imitator today. So I'm presenting to you a 15-year-old young man who was previously healthy. He presented with right eye pain and blurry vision for the past 3 weeks. These were his exam findings, but just to highlight, he presented with hand motion vision on the right eye, corneal edema with a pressure of 56. And when we did get a chance to look at his retina, he had an obliterative vasculitis with a venous predilection, as you can see here, and some vitreous hemorrhage on the right eye. At a glance, the left eye looked normal. So the differential diagnosis for a patient presenting with an occlusive venous predilection vasculitis is a vast differential. I use Intima to break it down. I know some people use vitamin C just as a memory jog. So on history, we managed to narrow it down a little, and then on bloods, we came up with nothing. So we were stumped. Just as the patient was leaving the room, we thought, Is there a TB contact in the home? Yes. In fact, the mother had been treated for pulmonary TB in the past year. So tuberculosis, while a quarter of the globe's population is already infected with TB, it's the leading infectious cause of death still to this day. There's a 50% mortality without treatment, and even with treatment, a 15% mortality. So this is a heat map of where TB is the biggest, has the highest prevalence in our country, in South Africa. This is where I'm from, so it is a hot spot. Please don't use this to decide where you're going to visit in South Africa. So we diagnosed our patient with Eales disease. He fit the typical patient bill. He's young, he's male. The disease is bilateral. I'll show you that later. Living in India? No, but a TB endemic area. It is technically idiopathic, but studies have shown that they've found positive mycobacterium culture on epiretinal membranes of patients that have Eales disease when past-spinal vitrectomy was done. So Eales disease is a diagnosis of exclusion. However, one needs to have a high index of suspicion in TB endemic areas and in cases of a contact history, as in our patient. The role of a Mantoux and quantiferin gold, what about using that to help us diagnose Eales disease? Well, it's not very useful in TB endemic areas. My Mantoux is probably positive. I've never tested it, but I mean, I've spent so much time in the healthcare system in South Africa, I probably have been exposed to TB. The most helpful diagnostic modality is the fluorescein angiogram. This is the fluorescein angiogram of our patient's left eye. And on the early phase, they typically show perivascular staining. And on the late phase, you can see extravasation of dye. And then the more obvious features of Eales disease were present on this patient's right eye, showing neovascularization, areas of capillary non-perfusion, and shunt vessels. So what are the management considerations for a patient with Eales disease? Observation is appropriate if there's no active vasculitis. Medical therapy, systemic steroids, 90% of the time are more than adequate. Immunosuppressants can be considered for patients that can't tolerate steroids for whatever reason, but it is definitely indicated for bilateral disease and during the inflammatory phase. Anti-TB treatment, this is a little controversial, but I think most of us living in these TB endemic areas, we would rather treat than not. But especially if there's extensive vascular involvement or a high clinical suspicion of TB, then we treat these patients. So management considerations, interventional therapy. This is indicated for active neovascularization, capillary non-perfusion on fluorescein angiography, and macular edema. This can be in the form of PRP, anti-VEGF agents, and periocular steroids. Past-spinal vitrectomy is reserved for patients with vitreous hemorrhage that doesn't clear or tractional retinal detachment. So back to our case. We treated him with 2 monthly bevacizumab injections plus orbital floor steroids and followed by scattered PRP. We initiated him straight away on anti-TB treatment, and we started him on oral steroids for the benefit of the left eye after commencing the TB treatment. So this was his outcome. Unfortunately, he'd lost vision on the right eye. It improved slightly to counting fingers. I'll show you why in a second, why his vision, unfortunately, has a poor prognosis on that eye. But the eye had quietened down completely, vitreous hemorrhage had resolved, and on the left eye, the vasculitis was resolving. So unfortunately, you can see here on OCT why he is unable to see. He's got extensive inner retinal layer loss. So my take-home is my learning points that I learned from this case was that I need to be familiar with the many phases of tuberculosis. I need to maintain a high index of suspicion to be able to pick up these patients. And just as we need to be good at what we know in the Word, we need to know the Word of God really well. We also need to know our work really well so that we can help the patients that are around us. Thank you.
All right. That was an excellent talk. Great job, Dr. Pons. We got our next speaker here. Brian Munoz with his talk again, Artesian extraction, removal of phakic IOL, and the art of precision.
All right, good morning, everybody. I came to play ball, so let's play ball. Without further ado, my name is Brian Munoz, fourth-year medical student. Today I'm going to be talking about the removal of a phakic IOL. So we'll get us started here. Clinical picture, we have a 61-year-old female who presented for a cataract consult. She had a history of a varices lens, or an artisan lens, phakic IOL, both eyes. And I'll just stop really quick show of hands. How many of you guys have seen this lens out in practice? Awesome. How many of you have implanted this lens? Okay, a little less hands. And how many of you have taken them out? Awesome. Okay, perfect. So important, this lens actually peaked in popularity back in the 90s and in the 2000s. So why is this important now? Because these patients are now developing cataracts, so you're going to see more of these patients coming into your practice. Back to the case, our patient had an uncorrected visual acuity of 20/80 in both eyes. Corrected visual acuity was 20/30 in the right eye, 20/25 in the left eye with the refractive correction that you see up there. So what is important, or what do we need to take into consideration when we're planning to take this lens out and do a cataract extraction? So the first thing is, how do we take this thing out, right? Do we cut it? Do we leave it intact? Do we go in through the cornea? Do we get more creative? Biometry, does the phakic IOL interfere with the biometry? Now, our patient had this because she was a high myope, so we have to plan for a potential refractive surprise afterwards. She had prior intraocular surgery, so what does this mean? Her iris had been manipulated before. Does she have a floppy iris? Is she a poor dilator? These are things that we don't know as we're going into surgery. And then lastly, does she value spectacle independence or not? So moving on to biometry, there's a few things that you'll notice. The first thing is that the target refraction was set to -150. Now this was done for a couple of different reasons. Our patient was so myopic that there weren't low enough powers in the typical one-piece acrylic lenses to get her to plano. You'll also notice that she had an extreme axial length of over 30 millimeters in each eye. How many of you guys are like quivering in your boots at this point? None? Okay. So another thing to consider is that these patients with these extreme axial lengths tend to have hyperopic surprises afterwards. Additionally, if we want to do a refractive tune-up, we want to make sure that our patient is left myopic for potentially better outcomes. And then lastly, you'll notice that she has a ton of astigmatism. Speaking of astigmatism, we move on to our topo here. You'll notice that there's a lot of significant against the rule astigmatism. Now this was likely due to a prior insertion for the artisan lens, not an ICL. At this point, what lenses would you consider? So quick show of hands, who would consider a standard monofocal lens on this patient at this point? Okay, so a couple residents, maybe throw on some glasses or contact lenses on afterwards, right? All right, what about a toric lens? Okay, a little more hands going on, a little toric lens maybe with some caveats. Perfect. How about any cowboys in here? Who would consider a multifocal lens? No? Okay. LAL? No? Okay, a couple LALs. If you saw Dr. Kim's lecture yesterday, you might consider a piggyback LAL in the sulcus with something else in the bag. And any other options, you guys get creative, we can talk about it afterwards. Well, I'm going to tell you how our surgeon did a multifocal lens. We did PanOptix bilateral in this patient. I'm just kidding, that's not what we did. So we actually did toric lenses, and up here you'll see the calculation for these toric lenses alongside the lens that was actually placed in each eye. At this point, you're kind of realizing, hey, this is not a diagnostic mystery. You're right, it's not a diagnostic mystery, it's more of a surgical challenge. That's what we did for the right eye, and here's what we did for the left eye. I'll see how many of you are awake. Perfect. All right, so this being the more surgical challenge, being the mystery of the case, and by now I'm probably running out of time a little bit, so I'm just gonna go ahead and tell you what we did. Our surgeon actually decided to go in with a superior scleral tunnel approach. He had experience doing M6 overseas, and he did this for a number of reasons. The first one was good incision architecture. The other reason, it would reduce the amount of astigmatism. So now a clear corneal wound is totally reasonable. However, you are going to be left taking some sutures out, and you will induce astigmatism. The lens was then extracted using, or de-enclavated using IOL forceps and a Connor wand. And then lastly, it was taken out through the tunnel using IOL graspers. And then finally, clear corneal surgery, cataract surgery was done business as usual. Intraoperative aberrometry was also done just to recheck our measurements, which were really close to the original. If you notice back in this slide over here, you'll notice that the lens that was actually used was different than the one that the calculator gave us, and that's because of the intraoperative aberrometry during the time of surgery itself. And post-operatively, so how did our patient do? Well, our surgeon says he got pretty darn lucky. Our patient actually ended up post-op month 1 at 2025 without glasses, mildly myopic in the right eye, but she was happy. She was reading up close, she was seeing at a distance, so she ended up with no glasses. So, you know, a little bit of luck, a little bit of prayer, and a lot of planning will do you good. I'd like to give a special thanks to my mentor, John David Stevens, and also to the COS for giving us this opportunity with the grant to be up here and present this case. So thank you guys. Any questions, or that's for later? All right, cool. Thank you guys.
Yeah, we'll have a quick 5-minute Q&A at the end of all the presenters. We'll have them all come back up here for the Q&A. We got Dr. Warren here, and then we got Dr. Wong on deck.
Good morning, I'm Melissa Warren. I'm a PGY3 at Albany Med, and today I'm going to present a confounding case of conjunctivitis. Oh, okay. Thank you. So our patient was a 4-month-old girl with no past medical history who presented with 2.5 weeks of redness, tearing, discharge from the right eye, no systemic symptoms. So here we can see an external photograph of mostly the right and some of the left eye, and our attention is immediately drawn to the right upper and lower eyelids with moderate erythema and dense white membranes on the palpebral conge. The bulbar conge was white and quiet, and the corneas were clear with no staining. Her left eye, the lids and anterior segment unremarkable. DFE was normal, both eyes. Vision was central steady, maintained. IOP was normal, no APD. So this patient had initially been seen by an outside comprehensive ophthalmologist before being referred to our pediatric service, and she'd been treated with ciprofloxacin drops, Pred Forte, no improvement. When we saw her, we increased the frequency of the Pred, also tried Polytrim. She came back and forth several times over the next month and a half, and there was no improvement. We also tried erythromycin ointment, peeled the membranes a few times, sent it to the lab for culture. It ended up growing H-flu, but even despite adequate antibiotic coverage, there was no improvement in her symptoms over a whole almost 2-month span. So what now? My attending had the suspicion, hey, maybe this isn't an infectious cause of conjunctivitis, and we actually ordered some lab work. So we ordered plasminogen, CBC, PT-INR, and PTT. All this was normal, except for this patient was found to have low plasminogen. So what she had is ligneous conjunctivitis, and it's named for the membranous woody lesions of fibrin, and it's most commonly associated with a plasminogen type 1 deficiency. So plasmin, the active form of plasminogen, is important for breaking down fibrin clots. So these patients develop these large fibrin plaques. Fibrin's important for the wound healing response, and so they pretty much get stuck in the granulation phase of healing and end up with these plaques. And it can occur on other mucous membranes, including your gingiva, your internal ear, your respiratory tract, female genital system, and kidneys, and it can be life-threatening if airway obstruction occurs. And it may be triggered by local injuries, local systemic infections, and surgery. And the prevalence and incidence is not entirely known because it's so rare, but it has been reported all over the world, including Japan, India, Turkey, Brazil, France, Germany, and the US as well. So treatment for this condition includes some topical drops. Plasminogen drops have been now considered the gold standard. However, it's not commercially available in the United States. You have to enroll in a clinical trial to get the plasminogen drops. It's also can be treated with heparin drops as well as steroid drops, fresh frozen plasma drops, serum tears, such as what our cornea specialist prescribed for dry eye has also been found to be effective, as well as cyclosporin drops, and it's also possible to treat this condition with IV plasminogen infusions. So our patient was treated with serum tears from her dad, who had normal plasminogen levels, and she had resolution of the membranes over the next 2.5 months. The family decided not to enroll in the clinical trial just because of the strict treatment regimen that was required and also the paperwork. But now she's been stable off of all drops for over a year, and we also plugged her in to follow with hematology. Just wanted to thank my mentor, Dr. Ness, and open up the floor for the next Super Bowl contestant.
All right, we got our next contestant coming up, and we got Dr. Harpole on deck after this for the order, just so we can get that squared away. We're off to an awesome start, some incredible presentations so far. All right, we'll give it over to Dr. Wong.
Thanks, Melissa, for not sabotaging me and giving me the clicker here. So my presentation today is titled On Tap Tonight, a Hazy IV, eh? So our patient is Mrs. K. She's a 77-year-old female with a past medical history of an NSTEMI, heart failure, aortic stenosis with a valve replacement, and cataract surgery in both eyes. And she presented with left eye blurred vision and mild pain for about a week. She notably was discharged 3 weeks ago from an admission for cholangitis that was complicated by E. coli bacteremia and pneumonia. And she already completed 2 weeks of IV ceftriaxone, and her PICC line was removed about 2 weeks ago. She also underwent ERCP and stone extraction when she was admitted previously. She saw an optometrist about 5 days ago. No records, but we know that she was started on Predforte and Cyclogel. And then earlier today, she saw a local retina specialist and was referred to the ED. Here's her exam. Her right eye was normal. Left eye vision was severely reduced at count fingers and had some mild corneal edema and 3+ AC cell. And in her fundus exam, she had 3+ vit cell as well. Glow of nerve was visible through the poor view, and there was what appeared to be a supratemporal subretinal abscess along her arcade. Notably, there was no string of pearls appearance to the vitritis. Does anyone want to offer any differentials at this point? All right. So there's endogenous endophthalmitis, which was top of our differential. There's bacterial. Notably, she had a recent E. coli bacteremia, so that was really top of our differential. And then fungal as well. She had kind of an indolent course, about 3 weeks going on. And then also wanted to keep in mind autoimmune panuveitis, things like sarcoid, VKH, vasculitis, and Sjogren's, as well as infectious forms of panuveitis, syphilis, TB, viral, and toxo, as well as PVRL, lymphoma, leukemia, choroidal metastases, and exogenous endophthalmitis, even though there was no risk factor for that in her case. So her hospital course, we had highest concern for endogenous endoph, so we did a tap and inject with Vanc, Ceftaz, and Vori, and she was admitted for IV ceftriaxone, and she was started on Durezol, Cyclogel, and erythromycin ointment. Her vitritis improved slightly over 3 days. Her vision remained stable, but her pain did resolve, and the cultures were no growth. She was also started on oral Moxie and discharged on the above drops. She follows up in retina clinic 3 days after her discharge, and overall, she's stable, so we just continued the present management. We also discussed the case with ID, and she was started on 6 weeks of IV antibiotic treatment with a PICC line, reinserted the PICC line, felt like the oral antibiotics were not sufficient to cover her disease. In the bottom left, I think the OCT probably already scrolled through, but there was slight hyperreflectivity of the inner retina layers in the fovea. And then in the fundus photo, you can see along that supratemporal arcade that there's this white lesion there. And overall, just vitritis murking up the view. She follows up 6 days after discharge By this point, her OCT had shown progression of the hyperreflectivity, and there was a worsening in her macular whitening, which I'll show in the next slide. This is just showing that hyperreflectivity is going full thickness now. And then in her fundus photo, you can see that right here, right in the fovea, there's this area that was not really there before, maybe a little bit of whitening there, but it's now progressed to be involving more of the fovea. And so at this point, we decided to repeat a tap and inject with Vanc, Ceftaz, and Foscarnet. We sent the aqueous fluid for PCRs this time. And nothing else was positive except for her toxo, which was highly positive. And we brought her back at this point, day 12, injected intravitreal clindamycin and dexamethasone as well, started her on oral Bactrim and a Durezol taper. And we repeated intravitreal clindamycin a week later. OCT showed extensive macular damage, and she deferred prophylactic Bactrim dosing at this point due to some previous experience with pruritus and transaminitis. And she was continuing on maintenance Durezol daily that she is still on today. And so this is just showing the progression of her OCT. At day 12, that was when we first injected the clindamycin, and then a week later, this cavity had formed where the hyperreflectivity was, which was resolving by month 3. And then the progression of her fundus photos, you can see that area of macular whitening has improved to the point that you just see that cavitary area there. And her overall, the supratemporal whitening has also improved, vitritis as well. So this was a case of toxoplasma chorioretinitis. It is the most common cause of infectious chorioretinitis, and has varying prevalence in different areas of the world. But in Africa, there's 43% of toxocarriers will develop chorioretinitis. And it is transmitted by cat feces, as we all remember from medical school, and has the classic appearance of headlight in the fog, which you can kind of appreciate from the fundus photos. Testing is by IgM and IgG in the serum, as well as PCR in the aqueous or the vitreous. And notably, the IgG may be negative if they're immunosuppressed. And treatment is not always indicated, but can be warranted if they have macular optic nerve lesions, if the lesions are near major vessels, or if they have dense vitritis, or if the patient is pregnant, monocular, or immunocompromised. And there are 2 kind of treatment courses that people generally pursue: systemic pyrimethamine, sulfadiazine, and steroids with clindamycin, or systemic Bactrim with intravitreal clindamycin. And recurrence is highest in the first year of infection. And there's some evidence for prophylaxis. One prospective study found that prophylaxis with long-term Bactrim did reduce the recurrence from 24% to 7%. And so just quick learning point, I'm over time, but quick learning points here: avoid anchoring to a diagnosis if the clinical response isn't as expected. Also question the diagnosis and reassess frequently. And with uveitis, anything is possible. Be vigilant. And there is a lot of power in an AC tap, especially when things are foggy. So I want to thank my mentors at UK for helping me put this case together, as well as COS for sponsoring me here.
All right, great talk, Dr. Wong. We got Dr. Harpole coming up, and then we got Dr. Blanchard on deck.
All right, so I'm from the University of Kentucky, and as some of y'all may know, basketball runs pretty deep. I'm a big basketball fan, particularly Miami Heat. This is a Dwayne Wade jersey. And as some of you may know, Dwayne Wade was a big reason the UK was knocked out of the Elite Eight in 2003. So a lot of people hate him in Lexington, but he's my favorite. So my case presentation is I Can't Stop. No financial disclosures, learning objectives. This guy came into a cornea clinic with concern for a right eye corneal ulcer. He's a 46-year-old guy, no past ocular history. Presented to an outside cornea clinic in Lexington. He had been hit in the eye with a rock while weed eating in early July of last year. Diagnosed with an abrasion, Saw the same doctor a week later. Had a total epi defect at that point, so was concerned for an ulcer, increased blurry vision. He was having a lot of symptoms. Cultures were taken at that time. He was started on moxie, as well as ofloxacin and E-mycin, and then he was sent to UK Cornea Service. So on initial exam, his vision in the right eye was pretty poor. He was 2200. Pressure was normal. Left eye was fine. And then on his anterior segment exam, he had upper and lower lid edema, this kind of eczematous rash around his eyelids. He was very injected, had some chemosis, and he had this very large epi defect with a large ring infiltrate. He also had decimate folds, some KP, kind of diffusely. And of note, he did not have any prominent corneal nerves, and he had 3+ AC flare. So this is a picture of his eye in the cornea clinic on our initial evaluation. And as you can see, he has this kind of ring-shaped infiltrate. And so our differential here, acanthamoeba was probably our number one, just based on the ring infiltrate. Bacterial keratitis, fungal, herpetic. We also had tetracaine overuse, topical anesthetic abuse on our list. And then I put Arcus on there just because it's ring-shaped. So testing management, we did send an acanthamoeba PCR out. And then we ordered prophylactically chlorhexidine for him to go pick up at the compounding pharmacy. And then we also started on bacitracin and atropine. The next evaluation, he actually admitted to using tetracaine 3 times a day for 2 weeks after his initial weed-eating injury. So I assume he presented to an ER, they gave him some tetracaine, and then he said that he had stopped a week before we saw him in cornea clinic, and we believed him. And so the next 2 days later, he missed his cornea appointment, came back to the ER 3 days after that, worsening pain, worsening vision. Our on-call resident was consulted. His vision was worse. He now had a large hyphema. And after some further investigation, he did admit to using the tetracaine quite a lot. And so this was his eye in the ER. It's hard to see, but he did have a hyphema there. And so this guy was diagnosed with topical anesthetic abuse keratopathy. It's often iatrogenic because these patients are given tetracaine, proparacaine, usually in the ER, but not always. Sometimes primary care physicians have access to this. Maybe optometrists and ophthalmologists will give this to the patients, but I hope that's rare. And then medical professionals, it's actually a little bit more common in because they have access to this. And so, ER doctors can sometimes have this. So risk factors, people with known addictive behaviors, access to the medication, of course. Psychiatric illness is also known to be linked to this disorder. And then it's more common in men. And I don't know if that's a testament to that we cannot handle pain very well. So how does this work? Topical anesthetics, they block sodium channels in nerves and dendrites. That stops the neural conduction along those nerves. It also inhibits epithelial cell migration and division, and it causes loss of microvilli. There's also deposits of the medication in cell membranes. And so how do you diagnose this? Almost always based on history, and it's also important to know, try not to trust everything that people say. Kind of take it for a grain of salt if you have high suspicion, but you always have to rule out acanthamoeba if you have a ring-shaped infiltrate. And then most importantly, stop the drop. And then, you also need to consider, does this patient need to be hospitalized? Can they be trusted to go home and not use a drop that they said they threw away? So back to our patient. The HSV and graft stains were negative. We did place a tarsorrhaphy on him. His epi defect was getting better and better. Then we took his stitch out. We put a BCL in. And this was him on August 14th. A little better, still not great. He continued to improve. That's him again. And then he had no epi defect at that point. In late August, we started him on pred. And then in mid-September, he had some filaments. Those got better. And then his eye looks fairly good. Thank you. These are my references. And thank you very much.
Great talk, guys. Awesome, awesome. We got Dr. Blanchard coming up, and then Dr. Berry with our last talk after him. All right.
All right. So, also from UK. Y'all have heard that multiple times now. My presentation is called Leaving Orbit. So, HPI, we have a 43-year-old male presenting with blurry vision and pressure behind his right eye, diplopia and periorbital edema with ptosis for 2 weeks prior to presentation in our oculoplastics clinic. He had a past ocular history of just one brief episode of eye redness that improved with some steroid drops a year prior. Pretty healthy guy, only medical problem is high blood pressure, and the outside general ophthalmologist had gotten a CT 1 week prior to him coming to the oculoplastics clinic, and it showed some right inferior rectus enlargement. His exam overall was actually not too bad. His vision was a little down compared to his left eye. Pressure and pupils were normal though. And his EOMs, he had a little restriction in up gaze and down gaze, but was full otherwise, and he was ortho. And then just, you can see his Hertels, he was slightly proptotic and had a little bit of edema and some ptosis, but his nerve was okay. If we, let's see. So there's an MRI on the left. You can see that inferior rectus is very enlarged, but really nothing else pertinent. And then the CT on the right, that was what he had the week before too. Same thing, very enlarged inferior rectus, but the rest of the muscles look okay. So we were mainly concerned for IOI. TED was also on the differential. You know, it likes to affect the inferior rectus predominantly, but in this healthy 40-year-old man that had no history of thyroid problems, we were less suspicious of that. So we got this extensive IOI panel, and we started him on Pred, 60 milligrams, and a PPI, and then scheduled him to come back in a week. A week later, he had some mild improvement in his edema and his pain. His vision was actually a little worse, though, and his pressure was borderline. But overall, the Hertels and the EOMs and the exam were stable. His IOI panel, really the only pertinent labs were a mild elevation in free T4, not really pointing to anything, and then the LDH was extremely high at 800. We'll come back to why that's highlighted in a minute. So because he wasn't really responding to our treatment like you would expect for IOI, we decided to sign him up for a biopsy and told him to continue on the Pred in the meantime. A week later, he called me on our 24/7 hotline when I was on call, and he said that he and his wife were on the phone, and he was in tears and excruciating stomach pain. He had been taking his PPI that we had given him 3 times a day, and every antacid he could get at Walgreens he was downing, and it wasn't helping at all. He actually had stopped the steroids a couple days after he saw us for the second visit because he thought that that was causing his stomach pain. And you know, we all worry about peptic ulcers with high-dose steroid use, but in a week or two of use, that's pretty unlikely. So I pushed him to go to the ER, and luckily, you know, as most men need, his wife pushed him to go to, and he listened finally. He went to the outside ER and had a CT abdomen pelvis that showed extensive masses, left psoas, adrenal, and his iliac wing, right lung nodules, and a larger mass in his pancreas that was compressing the common bile duct, causing his abdominal pain. His labs were critical values, multiple of them, so he actually got admitted to the ICU and had plans for an IR and GI guided biopsy of pancreatic mass and a bone marrow biopsy while he was there. So because of that, the orbitotomy wasn't important anymore. We canceled it. They were going to we assumed it was all the same process. And, you know, the bone marrow biopsy showed a concern for an aggressive plasma cell cancer, and then after they did the FNA of his pancreatic mass, unfortunately he had plasma cell leukemia. They tried every chemotherapy regimen that they could and every immunotherapy, including the salvage regimens, and he unfortunately did not respond to any of them and proceeded with hospice care and passed away. Just a little bit about plasma cell leukemia. It's a subtype of multiple myeloma. In this large European population study, it's extremely rare, 0.4 out of 1 million people. It's almost always aggressive and refractory to treatment, and the 3-year survival rate, as you can see, is less than half of people survive that long. The LDH that I highlighted earlier, greater than 300 was associated with a very poor prognosis. Our patient had an LDH of 800. So in a couple studies, you know, very short survival time, and only 20% of people responded to chemo regimens compared to people with a normal LDH, over half of them do. Specifically in the orbit, like we had, it's less than 1% of orbital tumors, and it can only really be distinguished on histology. Most of the case reports that are out there, patients don't do very well if they have orbital disease. And if you see this first, which does happen sometimes, with no systemic findings, you really need to refer them to an oncologist because greater than 50% of these patients are going to develop some form of cancer in the next year. This is just some summary slides from this meta-analysis from the oculoplastics team at Wisconsin, and I just highlighted the 2 points that I thought were very pertinent to our case. Only about 35% of patients that had orbital multiple myeloma or plasmacytomas presented with an orbital finding like our patient and had no prior diagnosis. And specifically, you can see our patient only had EOM involvement, and only 3 out of 51 patients had that in this meta-analysis. So it was a very rare case. Here's my references, and that's, yeah, we'll take questions later.
All right, and we got our last presenter here coming up right now. Let's welcome Dr. Barry.
Thank you. Okay, you might be wondering, where's my jersey, Daniel? Where's the jersey? Well, for me, my Super Bowl is Wimbledon, and my team is Roger Federer. So there's no jersey for that, but we got the hat here. So let's kind of get that situated. All right. So I want to just pause before. Dr. Friedman is here with us, and he's been my faculty advisor with this case, working alongside him, as well as Dr. Scott Sands, many of you of whom you may know. So Mount Doom, a fiery red and yellow disc ovary. So my fellow travelers, we'll be traveling to the deepest, darkest chasms of the eye. So grab your walking stick as we travel over hill and under hill. The journey begins, like most journeys, in a hole in the ground. In a dark room in an ophthalmology clinic, where a 55-year-old male presented for routine ophthalmological examination. He has no ocular history, medical history significant for diabetes, pretty well controlled, high blood pressure, hyperlipidemia. Says he had some alcohol abuse in the past, and also kind of endorses maybe some symptoms of obstructive sleep apnea, but really no other illnesses or concerns for him. As we look into the eye on the right side, he's seeing super well. Vision is great, and the exam is really unremarkable. You can see he doesn't have any retinopathy, and this disc looks great. As we look to the other eye, the great eye is upon us. Quite literally, as we stare into this eye, we see a Mount Doom of a looking disc here with flame-shaped hemes, 360, hyperemia, edema, there's vessel obscuration. As you can see, the vessels, there's some tortuosity. As we get into the periphery, we see some dot blot hemorrhages. This is very concerning. The vision, however, is 20/20. He's seeing super well, no APD, and the rest of the examination is unremarkable. So vision remains stable on close follow-up. However, there's persistent and worsening disc edema and peripheral hemorrhages, so a referral to neuro-ophthalmology was deemed warranted. Here he is a couple months after presentation. As you can see, disc edema, very prevalent, worsening hemorrhages, more hyperemia, and we even start to see some eruption of macular exudates, which are even more prominent here. Perhaps we could say a partial macular star. So, my fellow travelers, as you may grow weary of the burden of this case, let's convene, let's discuss, let's think about a differential. Centavo is from Italian centauri, which kind of means to wrap around. So I want us to wrap our minds around some things. We got to think about these different possible causes. Specifically, I want us to focus on, of course, inflammatory, infectious, traumatic, vascular, and of course, we're always concerned for anything pressure-related, ICP, IOP, or blood pressure-related. So we got a visual field. His left eye, no visual field defects. Right eye, some nonspecific changes. But overall, of course, our left eye is the eye of interest. Nothing that is of concern here. We decided to send him for a laboratory workup. His H&H and platelets are normal. His inflammatory markers are normal. And some Bartonella and syphilis, as kind of our infectious screenings, come back negative. And our inflammatory ANA, or autoimmune, rather, is negative. An MRI of the orbits was deemed warranted, and it really didn't show any inflammation of the nerve, or masses, or tumors, enhancements, just some nonspecific white matter changes in the brain, perhaps microangiopathic changes representing. A lumbar puncture was then performed, and it was rather clear and normal. The opening pressure, normal at 11 cc's. CSF, no growth. Of course, we can see here glucose is elevated considering his systemic diabetes, not uncommon. And then protein, it kind of flags that. Protein can be sensitive for pathology, but it's not necessarily specific. Of course, we have to clinically correlate. So this is where it was at the worst with his disc, a couple months after presentation, and here we are 6 months later with some resolution. And vision is still 20/20, uncorrected. So here at the end of all things, he has excellent visual acuity, the disc edema is resolving, and the warranted but limited workup was rather unremarkable. So the things that we're considering, this could be a very mild form of NION. Diabetic papillopathy would fit under that. Typically, though, the time course is a little bit less than our patient. Neuroretinitis is also differential. Of course, Bartonella is negative, but when we consider neuroretinitis, there's also idiopathic causes. The timeline and the macular exudates may fit a little bit more with this patient. And then papillophlebitis also, this is more of an inflammatory type of vascular course, not as well understood, but does last a little longer, does have some peripheral hemorrhages and tortuosity of the vasculature. So, there I'm back again on the journey. Thank you.
All right, that was awesome. This most highly anticipated event. It is now time for Q&A. So we'll have all of our contestants come back on up onto the stage, and while they're coming up, we have a little video. AV team, if you guys could please show that with some screenshots on exactly how to access the voting on the app here on the schedule, Super Bowl Grand Rounds. You'll see that icon right there. And then you click on it, Super Bowl, and then you can select who you would like to vote for. Difficult decision, all right? We had some incredible presentations today. And so we're going to open it up. We'll have everyone out here. We got about 5 to 10 minutes. I think we're a little ahead of schedule. Good for us. So we're going to do a couple of questions. Ask any contestant, any case that you want. If you have any questions, let's see. Show of hands. Anybody have any questions here? And then we will vote, and then right before the break, we're gonna have everyone come back up again, and then we're gonna give out the prizes, or at least we'll have at least first, second, third, and fourth, because there's a mystery prize, really cool. So really important who you're gonna vote for. Any questions, anybody? All right, here in the back, yeah, Gene, we got a question here. Perfect.
So for the TB case, you had a presentation with a pretty high IOP in the 50s. Was there much that had to be done throughout to handle the IOP, or did it just resolve quickly on its own?
Yes, thank you for the question. We put the patient on maximal IOP lowering treatment for that. Yeah. Diamox and a complement of topical medication.
For the last case, Dr. Berry, I don't know if I missed the blood pressure of the patient, and did you do an A1C?
Yes, the blood pressure was normal. It was pretty much like 119 over, 79 or something like that. So he's pretty well controlled. And then his last A1C, selfie, was 7.3. So he was pretty well controlled.
For the tetracaine abuse case, the emergency room physicians, there's literature saying that it's safe to prescribe topical tetracaine. So I think it's hit or miss each emergency provider how comfortable they feel, and I would assume that they counsel patients to only use dispensed tetracaine very infrequently. But with this case, was there an opportunity to circle back with the emergency room as a whole, or maybe that individual provider, to give feedback on what you see? Because I think that can influence greatly their practice patterns. If you're in a teaching hospital, maybe even a grand rounds there to show them what can happen. I think it's a great opportunity to illustrate the dangers of tetracaine abuse. And then, a question, do you know the volume of tetracaine of the bottle that they gave to the patient? Was the typical 15 ml, or was it like a surgical, whatever that, like 2 or 3 ml bottle was?
Yeah. So unfortunately, he went to a local ER like an hour and a half away from Lexington, so I never got to talk to that ER physician. But the physicians at UK certainly know not to give that out, and we've talked to them before. And also, I don't know what size he had. I assume it was a little 2.5 milliliter bottle, but I'm not sure. But it would have been nice to at least talk to whoever gave him that and let them know it's probably not a good idea. Yeah, but at UK, it's pretty well known.
I want to follow up on that. What was your hypothesis for why there was a hyphema in this case?
Yeah, my guess is eye rubbing. The guy was, even in clinic, he was rubbing his eye vigorously. So that's what I assume. But any other ideas would be welcomed.
I also just had a comment on the anesthetic abuse. My last case was a pharmacist who suffered a corneal abrasion and was using it herself until she realized that was the cause of her problem. But she informed me that physicians can actually write a prescription for proparacaine and pharmacies will fill it. And this is in North Carolina. So that can also happen. And I had another quick question on the last case. I was wondering if he was evaluated for sleep apnea and if carotid Dopplers were done.
So that was recommended at initial presentation by Dr. Sands, actually. So I don't actually know the results of that. And the carotid Doppler, I'm not sure exactly about carotid Doppler either. But for sleep apnea, for sure, he was recommended to discuss with his primary and do that.
For the ligneus case, was there much that had to be done for the cornea? We usually end up with long, protracted treatment times where the cornea starts having a lot of problems.
She actually never had any epidefects on her cornea, and she was otherwise behaving normally, wasn't rubbing her eye a lot or upset. She was only crying when we were yanking her eyelids open, really, but otherwise she was acting normally.
On that, for that case, were there any systemic concerns or conditions that the baby had, or was it just local to the eye?
It was just the eye. So actually that, even though it can occur on other mucous membranes, it's most commonly the eye, and that's thought of because the palpebral conch is more exposed to irritants or irritation than other mucous membranes in the body. And then because it's thought to start from an initial insult, maybe she had some viral conjunctivitis or corneal abrasion that caused that, and then once the ligneous compart was healed, she's been off of therapy now for a while and been doing well.
Awesome. Cool.
We're ready for vote.
One more question, Doc. The legend has a question. We can't. We can't.
Brian, in taking out that artisan lens, did you dilate that patient intraoperatively, or did you dilate him before you took out that artisan?
So I actually didn't do the surgery myself. I'm a fourth-year medical student. But my mentor, I'm assuming he probably did not dilate the pupil when he was taking out the lens and then dilated afterwards as he got ready for cataract surgery. But that's a great question, and I'm not entirely sure what the answer is. I'll ask him.
Is it a sulcus lens? Somebody raised their hands that they'd seen this lens before. Has anybody, is that, you want to comment here? Do we have?
Wait a minute.
Sorry, in my extensive N of 2 with these lenses, I actually did dilate them preoperatively because obviously the pupil is still moving while the lens is there. It's a little bit challenging to get the lens unclipped from the iris, but once you do that, it's just a matter of sliding it out through the tunnel and then taking the cataract out by whatever means you deem necessary.
I'm curious, for your N of 2, did you also do scleral tunnel to remove the lens?
Yes. So this patient actually had axial lengths of 35 millimeters, and so she had a pretty extensive posterior staphyloma in both eyes. She ended up, I believe, 20/60 in the better seeing eye, best corrected just because of macular pathology. I think she was 20/80 in the other. But we ended up putting in some pretty low power lenses for her. But she was reasonably happy, but she actually had mature cataracts in both eyes, so I ended up M6ing one and then phacoing the other. Gotcha. But yeah, I figured the M6 was actually pretty easy. I just made a normal M6 tunnel, took out the lens, took out the implant, and then took out her cataract.
Football related. I don't know if I can answer that. I got the hockey jersey on. All right, here. I had a nightmare last night that I Steve Harvey'd this, so just give me a second. Make sure I don't, announce the wrong person here. So we've got, coming in, tie for third, we've got 2 of our 3 Kentucky crew. Please give a hand to Dr. Wong and Dr. Blanchard. Come on up, guys. Yeah. All right, these guys are just awesome. So grateful that you both presented. Yeah, we go way back. Blanchard, come on up on the stage here, man. He reminded me one day when I was in residency, he was a med student rotating with me. We had this really crazy busy call clinic, and I got some like inpatient peds consult, and I was like, hey man, can you go dilate this baby's eyes? He's like, wait, what? I'm like, yeah. And I just hand him all the drops. I'm like, run up onto the NICU, ask a nurse for help, and he did it. So he's awesome. We've come a long way. And then go ahead and open these up, guys. Congratulations. Let's see what we got here. I don't know if it's a blah button or a singing goat, but we have some prizes for you. Okay, well, there you go. And also, we have a webcam. All right, that's a pretty good prize. We got some. Jesus is always watching, and a $10 Starbucks gift card for everybody here. So hang on. We're gonna take a picture. Give these guys another hand. Thanks, guys. And coming in at number 2, a fascinating case. Please give a hand to Dr. Warren. Come on up here. That was a great case, just incredible. I mean, that's really another use for those autologous serum eye drops, right? Can cure ligneous conjunctivitis in a baby. So, learned that today. Thank you so much. Great job. Come on over here. And you probably know who has already won here, but you don't know what. Oh, go ahead and open it up. Let's see what prizes we're giving out here. These were supposed to be the prizes for, I think it was last year, but then we had to get something else because we forgot them. Anyway, so I haven't seen these for a while. Okay, there's this. Oh, this might be is this the one that sings? Maybe this is the one that sings. We'll work on that later. That's in honor of Max Stu again. Okay, great case. Thank you so much. And then our last case, the prize, which I've built this up, is from iMobile. Sponsor this. This is super exciting. We've got an indirect ophthalmoscope. So that's the first place prize. Give me a drum roll, please. And we got Dr. Emma Pons with first place. Give her a hand. Woo! Great case, Emma. Congratulations. Here is your indirect, and it also has your name engraved on it. So go ahead and take that out. Take a look. Super, super cool. Super exciting. Yeah, show everybody here what you got here. Check this out. Yeah, don't be careful. Be careful. I'll take the case for you. Yeah, lift that. Show them what you got. You got an indirect ophthalmoscope. Super exciting. That will come into handy for years of use. So perfect. Perfect. And a Starbucks gift card. There's that too. So, all right, guys. One more hand for the contestants. Congratulations. It is another great Super Bowl. The 49th Super Bowl is in the books. So break time. Guys, we'll get a picture with you real quick. Come on right up here, and then we will call it a day. All right, thanks, everyone.